Hi, hello everyone. I think I'll leave it like a couple more minutes and then we can get started. But just to check, can everyone see my screen?
Yeah, we can.
Thank you. Okay, cool. Just give it a minute. Okay, yeah, we just get started now. So hello, welcome to Cardiff Student Psychiatry's first online teaching session. My name's Kate, I use she, her pronouns. I'm going to be talking a bit about schizophrenia and psychosis today. Please bear with us, this is our first session, so like if we have tech issues, that's why. And yeah, I've put a link in the chat. I'll resend it in case you can't all see it. But it's just to like a pre-session questionnaire. So it'd be really great if you can fill that out, because what we'll do is we'll send out the recording to the session and also the slides with like the cases and SVAs to the email addresses that you put on the slide. So yeah, there'll be a questionnaire at the end as well. So yeah, just before we get started, just put some content warnings in. So obviously we're going to be talking about schizophrenia and psychosis in quite a bit of detail in this talk, but there's going to be one slide as well that will be briefly touching on themes of suicide and self-harm. So I will like warn you when that one's coming up, so you can just like mute me if you don't want to hear it, and I'll let you know when we've like finished talking about it. But yeah, as always, if you're like affected by any of these topics or feel like you need some extra support, then there are lots of good places of support out there, so please like use them. And yeah, the aim of these sessions is essentially going to be focusing on what we need to know for the exams. You know, we've got progress tests coming up, and so we're just kind of trying to include, you know, the things that come up in PT. But I've also thrown a bit in there, so it's going to be kind of relevant to ISCI as well. And yeah, the specific learning outcomes for this session is just, it's going to be kind of in two main parts. So I'm going to start off by talking about psychosis, knowing that psychosis is different to schizophrenia, and then also going through what the symptoms of both psychosis and schizophrenia are, as well as the management. So yeah, this session is going to be quite interactive. So if you could just use the chat function, that'd be really great. But first of all, what do you think psychosis is? So if you just kind of put into the chat either like a definition or just keywords that you think are relevant to psychosis. Yeah, great. So Devon's put loss of contact with reality. Does anyone else have any other thoughts? Nice. Yeah, so lots of kind of similar answers, like interpreting reality differently to others around you, perception of reality changes, and nice, hallucinations and delusions. Yeah, so exactly. So the kind of like, I guess, official definition of psychosis is that it's defined as like an acute mental state which is characterized by delusional beliefs and hallucinations. And I guess the kind of main misconception I want to clear up with this slide is that schizophrenia isn't the same as psychosis, and not only people with schizophrenia will experience psychosis. So there's loads of different causes of psychosis, both psychiatric and non-psychiatric. So in terms of like psychiatric causes, lots of things. So obviously schizophrenia can be characterized by psychosis, severe depression, bipolar affective disorder, and also things like severe stress and anxiety can also cause psychotic episodes. And then you've also got things like substance misuse. So you've probably heard of drug-induced psychosis. Drugs and alcohol are big triggers. But then you also have other things. So it's really important to keep that in the back of your mind, kind of organic causes. So you've got lots of neurological disorders like Alzheimer's, Parkinson's, multiple sclerosis, and brain tumours. But you've also got other triggers such as hypoglycemia, HIV, AIDS, syphilis. In terms of syphilis, it's usually like quite a late stage feature. But yeah, it's really worth keeping organic causes in the back of your mind, because you can quite easily rule out things like hypoglycemia with like a blood glucose test. So yeah, don't always assume that it's going to be psychiatric in nature. And I've just put something very briefly on the pathophysiology behind psychosis. So for both psychosis and schizophrenia, dopamine is the neurotransmitter that's thought to be like the main one involved. So dopamine usually is involved in movement, attention, mood regulation, cognition, pleasure, and reward. And the main idea is that in psychosis, there's an excess of dopamine. So this is resulting in overactivity of the dopaminergic system, which causes the symptoms such as hallucinations and delusions. And so this is kind of the opposite to Parkinson's, which is where you don't have enough dopamine. And it's just worth kind of knowing that, because of the drugs that we use to manage psychosis and schizophrenia act on the dopaminergic system. And so yeah, just to kind of go through some definitions, just to clear some things up. So again, is it okay if you just pop into the chat kind of what you think delusions are and what hallucinations are? Again, either if you've got a definition or just some kind of like keywords to do with it. Yep, so you've got delusions are beliefs you hold, fixed beliefs that don't fit with the social norms. Yeah, that's pretty much the definition for delusions. And what about hallucinations? Experiences that feel real but aren't. Yeah, exactly. So yeah, in terms of delusions, there's kind of a few like components to the definition. So the first thing is that a delusion is a fixed belief that's firmly held. And what we mean by like a fixed belief is that no matter what you say to a person who's having like a delusional thought or a delusional idea, they're going to be like unshakable. They're going to have an answer to kind of any questioning that you do against what they're saying. And so the thing is, when you're kind of taking history from someone you think might have a delusional belief, you do really want to be a bit annoying and ask lots of questions to kind of see if there is that fixed nature. So for example, say that you're on your psych placement and a patient has been referred in by their GP, and the GP has referred them because the patient's kind of saying that they believe that their house is being haunted, and the GP thinks that this might be a delusional belief. So when you're kind of approaching talking to this person, firstly, you're going to want to ask them, like, are you sure that your house is haunted? And if their belief's fixed, then they'll say, yes, absolutely. You might want to say, are you completely sure that there's no other explanation for what's been going on? And they'll say, yeah, I'm completely sure of it. And then what you want to do after that, if you've kind of determined that they're quite fixed in their responses, you want to offer them kind of an alternative option. So you want to ask them, like, say they were saying that there was like a bang in the night, it must have been caused by a ghost. You want to offer them an alternative reason for that bang in the night. So you might say, are you sure it wasn't just like a door slamming in the wind? And if they then kind of go, oh yeah, no, actually my house is quite drafty, maybe it wasn't a ghost, then you've kind of ascertained that that's probably not a delusion because it's not fixed. Whereas if they were like, no, absolutely not, that bang in the night were the ghosts that were haunting my house, then it sounds like a delusion because they're unshakable in their responses. And then one of you in the chat also said kind of outside of social norms. So to other people, it will seem irrational or unrealistic. And also not in line with an individual's previous spiritual or cultural beliefs. So for this patient in particular, you might want to ask them like, oh, have you always believed in ghosts? And, you know, if they say, yes, I have, then I don't know, that might make you think perhaps it's less out of their previous, you know, belief system. Whereas if they'd never believed in ghosts before and they're suddenly convinced that their house is haunted, then that does sound a bit more like a delusional belief. And there are so many different types of delusions. So for the purpose of time, I'm not going to go into all of them, but the two kind of main types are delusions of grandeur. So that's the idea that someone's delusion has kind of put them in a high position in society. So it's the typical beliefs that like, oh, I've been granted a special power. Or then conversely, you've got your paranoid delusions or your delusions of persecution. And that's the idea that someone's kind of out to get a person. And then in terms of the hallucinations, the kind of official definition is a sensory perception that occurs without a true stimulus. But essentially what that means is that something's occurring, like you're either hearing something or seeing something or smelling something, or you can feel something touching you that's not actually there. But it is worth mentioning that there is something called a pseudo hallucination as well. But this isn't a feature of psychosis. This is kind of like a phenomenon that quite a few people will experience, with some of the common ones being hypnagogic or hypnopompic pseudo hallucinations. So hypnagogic is a hallucination that occurs as you're falling asleep or you're going to sleep. And so that might be where you're falling asleep and you suddenly jolt awake because you've heard someone say your name and you suddenly wake up. That would be a pseudo hallucination. Or hypnopompic is one that occurs when you're waking up from sleep. So gonna start off with some of the cases. So for the first case, I want you to imagine that you're a medical student on your placement in A&E, and a 20-year-old distressed woman is brought in by her friend. And you notice that she's talking really quickly and keeps jumping from topic to topic. But you notice that she frequently mentions how she holds the light. And you find it quite difficult to take history from her, and she seems quite suspicious of you. And she also frequently looks over her shoulder. So what are kind of some of the key features in this history that you think are important or you'd like to know more about? So if you just, again, like pop in the chat certain questions that you'd want to know from this history. So what does she mean by holding the light? Worth asking about alters, as this is quite a common term used by people with DID, which is dissociative identity disorder. Drug history, yeah, exactly. Any regular medications? And has this happened before? Yeah, that's always a really good one to ask. And what she's looking at as well. Yeah, exactly. So highlighted some of like the, I guess, like the key points from this case. So the first one being her age. So she's 20. So it's always worth just keeping in mind with younger patients that this could be more likely to be like a psychiatric cause, just because we know that 80% of patients first present with an episode of psychosis between the ages of 16 and 30. So yeah, it's always just worth bearing in mind with younger patients. And then also put in that she's talking really quickly and keeps jumping from topic to topic. let me just check the chat if anyone's brought this up. But yeah, what do you think that we're kind of getting at from the fact that she's talking really quickly and keeps jumping from topic to topic? Yeah, exactly, flight of ideas. Yeah, so kind of alluding to some sort of thought disorder. So talking very quickly, that sounds a bit like pressured speech, and then yeah, jumping from ideas to from topic to topic sounds like flight of ideas. And then yeah, someone mentioned about holding the light, to ask more about that, because that sounds a bit like a delusion, perhaps like a delusion of grandeur. And yeah, someone else also mentioned how she keeps looking over her shoulder. And so this is like a really, I don't know, in ISCIs, if you've got a patient who perhaps is hallucinating, I feel like one of the easiest ways for them to portray this is by them like looking over their shoulder. So if you ever have that like in an ISCI, it is worth mentioning, kind of asking, oh, what are you looking over your shoulder? Can you like see something or hear something? What's distracting you? Okay. So continuing on with this case, so you then decide to take a collateral history from her friend, and the friend explains that the patient's been behaving differently for the past week, but her behaviour has been particularly different tonight, and this has never happened before. She's got a history of substance misuse, especially with cannabis and amphetamines. So again, in the chat, if you could just pop down like what your differentials are at this stage, and also what investigations you'd like to think about doing. Yeah, so Devon's put psychotic episode, mania. Got another person saying mania as well. And what about kind of like the investigations? Is there anything that you're going to want to rule out? Yeah, exactly. So drug screen. Okay. So yeah, in terms of the, oh, something else has come through. Yeah, so in terms of the differentials, yeah, so at the top of your list, you're probably going to be thinking potentially a drug-induced psychosis, especially with the history of substance misuse with amphetamines and cannabis. But exactly, you're going to want to be thinking about a first episode of mania, especially with kind of like the thought disorder elements, and you've got as well as the hallucinations and delusional beliefs. So you're going to be wanting to ask the patient a bit more about her mood, so whether she's experienced any depressive episodes recently, as well as, I didn't really put anything about her mood in the case, so you'd want to find out a bit more about whether her mood's been kind of super related. And then also thinking about things like brief psychotic disorder. So these are usually triggered by things like stress or grief. So you just want to ask the patient or her friend, has that been any kind of stressful things going on in your life recently, any bereavements? And again, yeah, Devon mentioned about infection screens, so you're always going to want to rule out any organic causes. So again, do a blood sugar to find out whether she could be hypoglycemic, delirium, or ask about a history of like head trauma that could be causing this. And then in terms of the investigations, if you've done your ISCIs, then you'll probably know a lot about VBoxes, but it's just like a helpful way of structuring things. So in terms of bedside, for any patient coming in, you're going to be wanting to do observations, as we said before, a blood glucose, as well as a neuro exam, but realistically, you're probably going to be doing kind of a full systems exam if you're clerking a patient. And then in terms of bloods, so FBCs to rule out infection, UNEs to rule out any kind of electrolyte balances, but also just as a baseline, LFTs as baseline as well, and then CRP for your inflammatory markers, as well as your bone profile. Does anyone know why I might have put bone profile down, like what I'm trying to get at with that? Don't worry if not, because I'm not sure how how common it is, but yeah, exactly, hypercalcemia. So yeah, the symptoms of hypercalcemia, like bones, stones, groans, and psychiatric groans. So whilst kind of episodes of psychosis are quite uncommon with hypercalcemia, you can see mood disturbances and cognitive changes and anxiety with hypercalcemia. So again, it's just worth bearing that in mind as like an organic cause. And then Devon mentioned drug screen. And then you would also consider, if there's like an indication that there could be a history of head trauma, then you'd want to do a CT head. And then yeah, your baseline ECG. So in terms of the management of psychosis, the aim really is just for as early as possible intervention with the first episode. So if you see a patient and you're concerned that they might be experiencing psychosis, then yeah, you're going to want to intervene as soon as possible. And with all things psych, your approach is going to be kind of like a biopsychosocial approach, so a combination of medication as well as psychological therapies. So this is taken from the NICE guidelines. So you'd want to offer individual CBT, so cognitive behavioural therapy, and then also potentially family intervention. And this would be in combination with an antipsychotic medication. So the NICE guidelines say that first line tends to be an atypical antipsychotic, but this is chosen on a case-by-case basis. But it could be something like olanzapine or quetiapine. But yeah, you decide on the specific one depending on your patient and their kind of comorbidities, risk factors, things like that. And also, again, making sure that you're providing holistic care. So for this patient, you might also consider a referral to a substance misuse clinic. Yeah. Okay. So that's everything kind of on psychosis. So just before we go on to schizophrenia, does anyone have any questions? I think I saw one question in the chat, so let me just find that.
Yeah, so there's one question of, do you think it's worth learning rarer delusions like Capgras syndrome for exams?
Okay, nice, thank you. Oh gosh, yeah, so this is something that comes up a lot on PassMed, isn't it? You've got all the kind of niche different types of delusions. As far as I know, in terms of Cardiff, I'm trying to think whether any of those have come up before. I think one may have come up previously in a progress test. So I think it's worth like being aware of them. But if you're gonna struggle kind of memorizing the different delusions that are like listed on PassMed, then I guess it's weighing up whether it's going to be valuable use of time to learn these quite niche things that are probably not going to come up as much in practice. So yeah, sorry, that's not very helpful. I guess it depends whether you feel like you've got room in your brain to memorize them, then it's worth doing it if you do. But if not, I wouldn't get too stressed about it.
Awesome. And there was also another question in the forms that is, have you got any tips on taking a history from a patient with psychosis in practice?
In practice, okay. I'd say kind of the things that we were bringing up, like in the case, I think say just be super observant. I think that's with all of psych, they really like a lot of the clues you're going to get is going to be just from what you're observing, not necessarily what's being said. So like we were saying, if you notice that someone's a bit distracted or seems quite, anxious, it's probably worth bringing this up or asking them about it rather than just kind of observing and ignoring it. So yeah, like if you notice that they keep looking at something, just kind of asking like, oh, what is it? Because that's going to, give you more information. Yeah, but also the other thing would be like, you just have to be really sensitive when you're talking about things like delusions and hallucinations. Like make sure you don't say like, use the word real. I feel like that's quite a dangerous word to use by saying like, oh, it's not real, because you know, it's real to the patient, and that would be quite insensitive and could possibly like create a barrier between you and the patient. So yeah, just try and be as sensitive as possible. Okay, are there any other questions at all before we move on? Okay, cool. If you've got any more, just pop them in the chat and then I'll get to them at the end of the next section. So, oh, sorry, something's come through the chat. Yeah, okay. So now imagine, so we've got the same patient from the first case, but this time she's presented, but the symptoms have been for 2 months. So now you should be thinking more about schizophrenia because of the time. So I've taken the diagnostic criteria straight from the DSM-5, and this kind of outlines how schizophrenia can be diagnosed when 2 or more symptoms have been present for at least 1 month, and they've been present for most of the days. And one of the symptoms must either be a delusional belief, hallucination, or thought disorder. And we're going to get into like more of the symptoms on the following slides. And there also needs to have been a loss of function. So this person really isn't going to probably not be coping very well in their like day-to-day life, struggling with, you know, day-to-day activities. And then you've also got to rule out any other cause of psychosis before you can diagnose schizophrenia. So some of the risk factors for schizophrenia, it's kind of believed that there's a combination of factors that can cause it, so including genetic, environmental, psychological, and physical factors. But it's worth noting that one single gene hasn't been identified, so it's not like there is a single gene that causes schizophrenia. But we do know that family history is the strongest risk factor. So if you have a parent with schizophrenia, the likelihood of you being diagnosed with schizophrenia is much higher. And there's also been lots of studies done with monozygotic twins. So if a child is diagnosed with schizophrenia, there's a 1 in 2 chance that their identical twin will also be diagnosed. And that's even if they're like raised in separate environments. So it's clear that there is like a genetic role. Other risk factors include complications before and during birth. So this includes things like prematurity, low birth weight, and lack of oxygen during birth. And it's noted that there are some subtle brain differences in these people. And then finally, we have the triggers. So stress is a trigger, as well as drugs, like particularly amphetamines, LSD, cannabis, but pretty much any drug. And it's also been observed that you can have some prodromal symptoms before a patient kind of has those classically schizophrenia symptoms. So this might include like in their teenage years, showing a loss of interest, kind of socially isolating themselves, or having self-neglectful behaviours, or experiencing depression, anxiety, or brief psychotic episodes. So the symptoms of schizophrenia can kind of be divided into like positive and negative symptoms. So just starting with positive symptoms, you're able to like put in the chat what some of the positive symptoms are. Yeah, exactly. A couple of people with hallucinations, delusions. Yeah, exactly. I've given you a bit of a clue of like where things start to happen. But yeah, these are the kind of 4 positive symptoms. So yeah, exactly. You've got hallucinations and delusional perceptions, and then also thought and speech disorder. So we've already kind of gone through hallucinations, but in schizophrenia, these are most commonly auditory. And again, there's lots of different types, but just some examples being third person. So that's where you hear voices talking about you, and this is usually in like a derogatory manner. So it might be like a running commentary of hearing someone say like, oh, you're really bad at this, you're ugly, that sort of thing. Whereas second person auditory hallucinations is where the voices are like speaking directly to you. And then you have thought echo as well, and that's where you hear a thought, you think a thought, and then you hear that thought aloud afterwards. So yeah, it's worth mentioning that you can probably imagine that these positive symptoms are super scary for patients because it can really feel like a loss of control. And then in terms of delusional perceptions, these are often described as like a two-step process. So it's quite difficult to explain, but it's where a kind of a neutral or everyday happening then links to a delusional perception. So the example I put is you might turn on a light switch and then a person who's having delusional perception might think, because that light's turned on, I have these special powers. Or if like a traffic light turns and changes color, then I have these powers. So something ordinary then triggers a delusional perception. And then again, there's a lot to thought and speech disorders. There's lots of different types, but I've just kind of put up some of the ones that seem to most commonly come up in exam questions. So you've got one called neologism, which is where a person might kind of make up and use a new word, or they might take two real words and combine them to make a new word. Or you've got word salad, which is where sentences are made up of real words, but they're just all jumbled together. So it's like a really nonsensical sentence. And then we briefly spoke about flight of ideas before, but this is where you quickly jump from topic to topic, but it kind of makes sense because you can see the links between the topics. So yeah, it really is just like a flight of ideas. And then you've got circumstantiality. So this is where you might ask someone a question and they just give you really excessive details. They spend a lot of time telling you about something, but in this really excessive detail, but it does eventually reach the point and you kind of do come full circle. Whereas in tangentiality, you never reach the point. You just keep going off and off with excessive detail. And then in terms of thought disorder, the most common ones are thought insertion, which is where someone might say that thoughts are being put into their head, or thought broadcast, which is where their thoughts are being shown aloud to everyone. And then with thought withdrawal, which is where they might believe that someone is taking thoughts directly from their head. And then next, the negative symptoms. So again, does anyone want to just like put in the chat what some of the negative symptoms are? I can give you a clue. In Cardiff, we taught about them as like the 4 A's. Yeah, so loss of enjoyment in life, abolition, anhedonia. Yeah, exactly. So yeah, you've got allodia, I don't know how to say it, but this is like a poverty of speech. So these are people who are really quiet. A literal poverty of speech. Anhedonia is the inability to feel pleasure, especially in things that would have like previously derived pleasure. Abolition is a lack of motivation, and then apathy is a lack of interest. And so all of these things are quite a poor prognostic sign because it's showing that there's really reduced function. So yeah, this is quite like a late stage but poor sign. Okay, and next, so in terms of other symptoms, so yeah, this is the slide that I will be talking a bit about suicide. So if you want to mute me, please, do what you need to do. But once I've changed the slide, I won't be talking about it anymore. So some of the other symptoms, these are just kind of quite more general psych symptoms, but changed eating behaviors. So this might be eating less or eating more. Sleep disturbances, again, so sleeping more often or less often. Impaired insight, so this is insight is something that you kind of would assess in a mental state exam. So someone with impaired insight might not realize that they're unwell or that something's wrong, whereas someone with insight would kind of be able to acknowledge that they might need some help and that things might not quite be right. And then also catatonia. So this is where you might see people in quite like abnormal posturings, holding these positions that would usually be really difficult to hold. And this is one of the indications for electroconvulsive therapy. And then, yeah, you always, with any patient, you want to be risk assessing. So you just need to be asking about whether they've had any thoughts of self-harm or any thoughts about suicide. And if they indicate that they have had thoughts of suicide, then you really need to ask more questions and find out a bit more. So kind of find out whether any plans have been made. So you might want to ask things like, have you made any changes to your will recently? Or have you kind of made any plans about when or where or like method? Okay, so yeah, going on to management. So again, you're going to be wanting to do a combination. So you're going to want to be looking at psychological therapies, so that's your cognitive behavioral therapy, as well as providing lots of social support, lots of follow-up, as well as medication. So as I mentioned before, schizophrenia is also thought to be due to an excess of dopamine. So the management involves drugs that block this dopaminergic activity. So for your first line, again, you're going to be wanting to look at your atypical antipsychotics. So things like olanzapine, quetiapine, risperidone, aripiprazole. And these kind of come in lots of different forms. So it can be tablets or depot. And you might consider a depot, so that's an injection that you can have. I can't remember how regular it is, but it's not an everyday thing. So you might consider this in patients who you think might not be compliant with medication or might not be able to take tablets. And then if that doesn't work, you've tried one antipsychotic and that's not worked, then you're going to try another atypical antipsychotic. And then if you find that that doesn't work, then this is what you kind of call your treatment-resistant schizophrenia. And this is when you bring in clozapine. So clozapine is a really great drug. It works really well, but it does have a lot of side effects. So that's why it's kind of used almost as a last line. Okay, so there's quite a bit of information on this slide, but this is something that does come up a lot in exams and also for like your medication stations in ISCI, so it is worth knowing. So in terms of typical antipsychotics, these are things like haloperidol and chlorpromazine. These aren't used that much as commonly in practice because of their kind of side effect profiles, but they do come up a lot in exams still. So these work by acting on the dopamine 2 receptors, and they have lots of adverse effects, including hyperprolactinemia, so that includes things like galactorrhea, and this is due to the inhibition of dopamine pathways. And then you also have the extrapyramidal side effects, and these are things that come up all the time in progress tests and on PassMed. So in terms of the extrapyramidal side effects, you've got acute dystonia, and this is defined as sustained muscle contractions. And an example of this is an oculogyric crisis. And so this might be where you have a patient whose eyes have become fixed or locked in an upwards position and they're blinking lots. So they have that sustained muscle contraction. And then you have Parkinson's symptoms as well. So these, again, just include your like classic Parkinson's signs of a tremor, bradykinesia, so really slow movements, or rigidity. You also have tardive dyskinesia, and this is these like involuntary muscle contractions, so things like lip smacking. And then finally akathisia, which is kind of this sense of like internal restlessness. And then in terms of your atypical antipsychotics, so those are the ones that we mentioned before, so like olanzapine and clozapine, And these act on a much bigger range of receptors, so D2, D3, D4, and serotonin receptors. And again, these have quite a few different side effects. So a lot of them cause weight gain and metabolic syndrome, so things like hyperlipidemia and type 2 diabetes and obesity, and that's especially common in olanzapine. Whereas in clozapine, the kind of classic exam question is a patient comes in, they're taking clozapine and they've got a sore throat, and you've suddenly found that their neutrophil count is really low. So in these cases, you're going to be thinking of agranulocytosis, which is essentially where your neutrophils drop really low to like less than 0.3. So in that case, you're going to be wanting to check the full blood count straight away to monitor for agranulocytosis for anyone who is on clozapine and presents with like a fever or a sore throat. And that's something that you're really going to want to safety net your patients on as well. And then I've just put a bit for the monitoring for atypical antipsychotics as well. So you're going to be monitoring them prior to the treatment, so to make baseline results, and then at 3 months, and then 12 months, and then annually. So you're going to want to be checking your blood pressure and weight and HbA1c, fasting glucose, lipid profile. So that's all for your like metabolic syndrome symptoms. For ECG, you're going to want to checking that because clozapine particularly can also cause myocarditis. So you're going to be wanting to check the ECGs to make sure there are no changes there. And then again, as I mentioned before, your full blood counts, you're going to be wanting to check that, especially with clozapine for the agranulocytosis. So just to finish off, I've got a few SBAs. So hopefully this works. So I've made a poll. Has that launched? Can anyone see that poll?
Yeah, that's working.
Thank you. Okay, so I'll just read through the question. So yeah, you're on your GP placement and a patient comes in presenting with some abdominal pain, and you start to take a history from this patient, but quickly become concerned that the patient may have a thought disorder. The patient says, I first felt the pain in my stomach when I went out for a walk yesterday. I went for my walk through the park and saw some swings. I always went on the swings when I was younger. I also liked to play football when I was younger. So what do you think this might be an example of? Okay, I'll give it a few more seconds. Okay, I'm going to end the poll now. So yeah, most of you guys got it right. So this is flight of ideas. So the reason why is because, before you were saying about how it's just like a constant jumping from topic to topic, but there are some links between the topics. So you can see with this person, they're talking about their pain and the fact that they went to a walk. And because they've thought about their walk, they've now started telling you about that walk. And the fact that they saw some swings then made them go on to tell you about them being on the swings when they were younger. So there are like connections between these different thoughts and ideas that they're having. So the reason why it's not circumstantiality is because in circumstantiality, they would probably more just tell you in excessive detail about firstly the pain, but also if they mentioned the walk, then they would probably tell you lots about their walk as well. But for this patient, they've not come back to the point. So in circumstantiality, they will always it will make a full circle. It will come back to the point. And the reason why it's not thought broadcasting is because thought broadcasting is more the idea where it feels like someone might think that their thoughts are literally being like displayed to the world around them. Okay, so So for the next one, we've got a patient with a background of schizophrenia attending A&E after developing new symptoms. And when you go to see the patient, you notice that both of their eyes are fixed in an upwards position and they're blinking excessively. And which of the following medications do you think have most likely caused these symptoms? Just going to launch the poll. Okay, give it a couple more seconds. Okay. So for this one, yeah, the answer is haloperidol. So this is your oculogyric crisis, which is like an acute dystonia reaction, which you get with the typical antipsychotics. So yeah, haloperidol is the only typical antipsychotic on this list. So clozapine, yeah, that's your atypical. Fluoxetine being an SSRI. Procycline is a anticholinergic, I think. And then risperidone is also another atypical antipsychotic. So yeah, these come up all the time, so it's like worth remembering your extrapyramidal symptoms. And then just to finish off the last SBA, so a 79-year-old patient is currently a patient on the respiratory ward with a community-acquired pneumonia. One of the nurses has raised concerns about his behaviour and mentions that he keeps referring to animals he has seen at the end of his bed. When seeing the patient, you notice that he is visibly confused, and on examination, he's apyrexial and has a catheter in situ. He's not opened his bowels for 4 days. So just launch that poll. So yeah, what do you think has most likely caused these symptoms? Okay. Yeah, everyone got that one right. Yeah, so this is delirium. So this is just my little reminder that you always have to kind of keep in the back of your mind whether there's another cause, so like an organic cause. So this patient in particular has a lot of the risk factors for delirium. So firstly, they're in hospital, which is a different environment, that they've got an underlying infection, it's got a catheter in situ, and also constipated. So these are all risk factors for delirium, which can cause symptoms that you might also see in psychosis. So yeah, that's everything. Thank you so much for coming. If you've got any questions, yeah, just pop them in the chat and I'll try my best to answer them. And yeah, please fill out the feedback form. We'll get you the recording and the slides if you want to look over them again. Okay. I'm just going to stop sharing. I'll pop the link for the survey in the chat. Okay, there we go. There's the survey. Anyone got any questions?
Have you sent that link in chat, by the way?
Oh, I accidentally sent it to only one person. I sent it to everyone now. There we go. All right, thank you so much for coming. We've got our next session on Tuesday the 8th at 6:30, and that's going to be just literally all SBAs in preparation for the progress test. So yeah, that should be a good session. Thank you.